you very much for coming to Athens and welcoming you. It is a great honor for me to be among you and so experts and special speakers and scientists, doctors. And it was appreciate the idea of Despina to have these joint sessions between Egypt Summer School and local doctors in order to be open and be able doctors who are interested in immunology, and especially primary immunodeficiencies, which are inborn errors of immunity, in order to have the opportunity to follow, to join this session, either lively or via internet. And so we all know that just 2 seconds to say that we all know that infections are the most common manifestations, symptoms of primary immunodeficiency, but we have to take care not to forget the other manifestations like autoimmune, allergic manifestations, malignancy, and autoinflammatory diseases. So if we do that, if we don't think about it, for sure we lose about 25% of the patients, because at least the infections is not the initial symptoms, and sometimes infections take a lot of time since the first signs of the disease. So thank you, and we can start with Despina. Dr. Moskos.
So, ευχαριστώ πολύ, Μαρία, για την ευκαιρία που θα είμαστε εδώ μαζί με εσάς για αυτό το Egypt Summer School. I will switch to English, nevertheless, for those who don't speak Greek. And so we are very happy that for years that we planned this event, 2020, 2021, 2022. So I'm very happy that Dr. Canariu helped us to organize this event, which is also being streamed. So I don't know how many people may connect and may also have the opportunity to see it afterwards. I think it will be available, as you told me, through the hospital site. So this is a great opportunity for us, and without other words and losing more of the precious time, I want to invite my dear colleague Manfred Hönig, who is a pediatrician and immunologist working in one of the most important centers for pediatric immunology in Germany, in Ulm, where he's treating patients with immunodeficiency and also transplanting him. So thank you very much, Manfred, and thank you for all you to be here for this meeting. So I'll go back.
So thank you very much, Despina, for the kind introduction and for the invitation. It's a pleasure and an honor to be here. And yes, we started with newborn screening for SCIDS in Germany 2.5 years ago. And Despina asked me to report about our experience with that. And I know very well that there is among you others who have far more experience, longer experience than us. But in the end, I think it's unpublished yet data, which I cannot show, unfortunately, but I'm going to go through the experience which we had with almost 2 million newborns now screened in these 2.5 years, and I hope that everybody can benefit from it. And I know that the audience is kind of heterogeneous, so I'm going to start with basics. And with a very philosophical question, what is SCID? And on the first hand, this is easy to answer. It's severe, which means children are going to die in the first month, in the first 2 years of life usually. And it's combined, which means that it's affecting specific immunity, cellular specific immunity and humoral immunity. And beyond that, we have one proper published definition by the colleagues in the US, and this is clearly defined by the cell counts in peripheral blood. So SCID is defined as an individual with less than 300 T cells in peripheral blood, and this is important, decrease in T cellular function, or the identification of T cells of maternal origin. So this is important to remember because I'm going to come back to that every now and then. So just a short timeline of the development. In 2008, Wisconsin started with newborn screening for SCID, and this ended in 2018, 10 years later, with all states all over the US being involved in the newborn screening. And on the bottom, you can see many countries all over the world, in Europe and beyond, who joined in the meantime. And I'm just going to go back to the question why we want to do that. And there is good reasons for doing that. And we know that from one, I think, very important publication from the colleagues in London, where they compared the outcome of children who were diagnosed at birth because they had siblings who were diagnosed before with severe combined immunodeficiency, and those who were diagnosed because they were symptomatic. And the difference in overall survival is quite astonishing, which is 40% in comparison to 90%. So this was always one of the major points we could make for having the newborn screening. And this is another very important publication by the colleagues in the United States, where they compared the outcome of children who were transplanted with infection and without infection, and those who were transplanted before the age of 3.5 months and those who were transplanted after this age. And you can see a clear advantage for those who are transplanted without infection at a young age. So newborn screening was integrated in the screening from the dried blood spots from the Guthrie card. And the technique which was chosen was a quantitative PCR, which took a byproduct of the VDJ rearrangement in T cells as a template. And you can see here the primers where they bind, and you get amplification of this product, which is taken out of the genomic DNA when the T cell develops in the thymus. So this byproduct, this little ring here, is called T cell receptor excision circle, and it can be identified by PCR. And if you do that, you find that this is in young T cells, which are just leaving the thymus, and then it becomes diluted with every division of a T cell, but nevertheless it remains representative for the activity of the thymus. And this is what we quantify in a quantitative PCR, and we define levels which have to be reached by children when they have a normal T cell system developing. So I'm not going to go into details how this test is going, because I think for our practical work this doesn't really matter, but we have to know some of the details, and I'm coming to come back to that. So how do we proceed with a patient tested positive? And I think this is one of the most important things, not to have the screening, but to have an algorithm what to do when you get the information from the screening lab that your patient is positive. And I hope that I have not forgotten anything. This is what we decided to do. So when we have from the first screening card, and this has to be adapted to the needs and to the structure of every country, and this cannot be just copy-pasted for another country or for another structure. So we decided when we have tracks below the cutoff, And then we have to divide whether it's just below the cutoff or whether the tracks are absent. If tracks are absent, if there is no amplification at all, we call them urgent positives. And if they are older than 32 weeks of gestational age, they come directly to an institution where they can be diagnosed with flow cytometry and where they can be treated. And the background of this algorithm is to avoid transferring these children to too many hospitals. So in the ideal world, they would be diagnosed as urgent positive, come to one center, get diagnosed via flow cytometry and genetics and so on, and then get the treatment in the same hospital. So the other things are far more complicated. So if they are preterm babies, we would, and if tracks are absent, we would maybe go for a second card or shift them directly to urgent positive. This depends a little bit on the gut feeling of the doctors. If they are older, we would ask for a second screening card before they go to flow cytometry and so on. So I'm not going to go through all the potential pathways, but I think this is very important, and we keep discussing this every screening meeting on, and there have been little modifications, I know, and I know that in the States it has been modified as well to the needs which you then have with the first experiences. So the next point I want to come to is that track-based screening is specific for T-cell leukopenia, but it's not specific for SCID. So we detect children, and we detect many children via this screening who are not SCID by the definition which I just mentioned at the beginning of my talk. And as I cannot yet show the complete data of our screening program, I took those published by the American colleagues, and the proportions are pretty much the same in our cohort. You can see here the typical SCIDs on the left-hand side, with the leaky SCIDs, including Omenn syndrome, here on the bottom. And the majority of the patients being detected by the screening program, and we have the same experience, and I think most screening programs have the same experience, are those whom most of us would not call SCID, but I think it's difficult, and it's maybe an endless discussion whether a T-cell negative DiGeorge patient is a SCID or is not a SCID. So in the end, I think we have to discuss, and we have discussed the last days in the summer school as well, that there are some problematic catches, as for example the patients with ataxia, telangiectasia, who might not really benefit from the screening, but I think in the end all of these patients, even if they are not the focus of the screening, at least to my impression, somehow benefit from the screening program. But you have to be very careful with the preterm group. This is why preterms have low track levels, and we know that. So we have to define some kind of filter for this group, not to cause too much efforts and too much trouble and too much anxiety at the patient side. But nevertheless, do not lose maybe the rare situation that we have a preterm baby with SCID. So this is difficult, and this is details. And the other thing is the secondary causes for T-cell lymphopenia, hydropic children, cardiac anomalies, gastrointestinal anomalies have to be dealt with very carefully at the treating centers then in the end, and there have to be a lot of, let's say, knowledge about this possibility not to treat or to mistreat a patient, for example, with bone marrow transplantation, who obviously doesn't need it. So I'm just trying to give you an overview of that, what could be called false positives, but I put it in parentheses because I think many of the patients in the syndromic group, DiGeorge's, charge syndromes, I think they are not just false positives, I think they benefit from the screening, but that's a matter of discussion, of course. They're not the target population. The Dutch colleagues just recently published an overview where they discriminated actionable and non-actionable secondary findings, and I just wanted to give you this definition, even though I think it's not that easy in my eyes, because defining children who are not in the target group but have low T cells or absent T cells, to define whether they are actionable secondary findings or non-actionable findings, I think this can be done only on a very individual basis. And the true false positives are those who have normal T cells in flow cytometry, but nevertheless have repetitively no tracks or low tracks. And we know some of the reasons for those as well, and this was published by the same group of Miriam van den Burg in Leiden, and they demonstrated quite nicely that these patients have polymorphisms in the primer binding regions of their tracks. So they have normal T cells, they have tracks, but these tracks just cannot be amplified by the quantitative PCR. So this is one reason. And how to filter out these, I think this is beyond having a screening implemented, the most challenging thing which we have to do. So just some words on the potential false negatives. What might those be? I just randomly took 3 of our patients from our cohort in Ulm and depicted their immunophenotyping, just very roughly. And you can see that the patient here on the left-hand side, he is having no T cells detectable, no naive T cells, and the others have naive T cells to almost normal content. It's not normal, but almost normal, and they would not have been detected in the SCID screening. But nevertheless, they presented clinically with an opportunistic infection with a clinically severe pneumocystis pneumonia. And the first patient was a typical SCID with common gamma chain deficiency. The second one presented at the age of 5 months, so in the middle of the best months of a SCID patient with this infection, and had a defect of ZAP70. And the third patient had an MHC class 2 deficiency. So they would be classified as less severe combined immunodeficiency, and I think, as so often in medicine, this is not a clear-cut border, but it's a spectrum which we have. And those patients, and this is the message I want to give, would not pop up in the screening, and nevertheless, they could clinically present as SCID. So what I want to say is, being here in Greek, with the pillars depicted from the internet, the 3 pillars of diagnosis of SCID are the clinical phenotype, immunophenotype, and the genotype. And with the newborn screening, we now create a building site for the clinical phenotype. So we want to avoid the clinical phenotype. That's the reason for the screening. But we still have to learn, at least in my perception, how to ideally build this pillar, and it is not as nice as the other ones yet. So how do we then want to proceed with a patient who is positive in screening and has the diagnosis of SCID? And this is another very important question, because what we want to avoid is that they come to transplant with infections. And what I depicted here is not from our SCID screening data, but it's from the National SCID Registry in Germany, together with Austria and Switzerland. We try to get data from all patients identified as T-cell deficiency, identified as T-cell deficiency in these 3 countries. And we started in January 2018. And the 1st of August 2019, we implemented the newborn screening. And what you see there is that the number of detected infections before stem cell transplant, at least in these very preliminary data, is going down. So this would mean there is an effect of the screening, but this has to be now verified with more patients, and I hope that the trend will go on. But nevertheless, we have infections for those who were detected in the screening, and this is an experience with which the American colleagues have had either. And I think in this very important publication, they compare again the group of patients who were diagnosed via family history and those who were diagnosed via newborn screening in the US between 2010 and 2014. And there is, from 59 patients, there is more than 20 with an infection. No, there is more than 20 detected via family history. And then there is only one with positive family history with a respiratory viral infection. And all the others, summing up to almost 20 patients, were detected in the newborn screening, but nevertheless became positive for EBV, respiratory tract infections, and CMV. So this is a bit of disappointing. And there is other things where they compared these two groups, and I'm not going to go through all the data, but the median time at transplant was much later for those detected in newborn screening. I mentioned already that the number of active infections was higher for those in the newborn screening, and the median age of diagnosis was higher as well for those detected in the newborn screening. So I think there is still not a long way, but some short distance to go to try to further improve this. And how can we try to avoid infections? And this is then my last slide, or this almost last slide. And I'm going to go through that in detail because I think this is the really important message, how to manage, and this has to be discussed on and on and on, how we can avoid these infections after positive screening. And just to give you an impression, we have to decide whether we bridge the time to transplant in an inpatient or an outpatient situation. This depends on the number of siblings who are attending public institutions as school or kindergarten. We have inpatient protective environments which are different in all our centers, and nobody knows whether gowns or masks or whatever is the right way or the wrong way. I think we have learned a lot in the still ongoing pandemic, but still there is a lot of heterogeneity in that. I'll be finished in a second. And restriction of access of non-staff caregivers, initiation of pneumocystis, prophylaxis, immunoglobulin replacement, when to start, when to do this, antifungal prophylaxis, antiviral prophylaxis, viral infection testing, and breastfeeding recommendations. And I think breastfeeding recommendations are probably the most important to avoid CMV infection of these young children before they come into transplant. And I think this has to be adapted to each country, and we are trying to define within our society the not the inborn errors, but the Working Party for Pediatric Immunodeficiencies in Switzerland, Austria, and Germany. We are trying to define these points in a guideline. Beyond that, we offered, and I think this was a very good idea, a screening hotline. And this was just 5 people, 5 experts who were 5 days a week from Monday morning to Friday evening could be reached by this number. Weekend is not really necessary because no results will be transferred on the weekends. And in the beginning, we were called quite oftenly. And now it's going down, of course, because people become more and more used to these screening results. But I think at least when you start a screening program, this has proven to be very, very helpful. And with this, I want to thank you for your attention. Just these are the name of our transplant center in Ulm, and we hope that we all have a nice summer. Thank you very much. And I'm happy to take your questions if there's time.
You were in time because I made it a bit before.
Okay.
So if there is a burning question, we can take it.
I wonder if you can comment on the cracks in addition to the tracks.
No, we have been discussing that for a long time, and then for many reasons we decided not to go for the cracks. I mean, this has been, in the end, I'm completely with you, Fabio, that we would catch more patients with including the cracks as well. So for those who do not know, this is a marker for B cell development and the presence of B cells. But this has been a long discussion, and I think in the end I'm happy that we just went with the tracks, because with all of these problems which we have to discuss, I think it would be an overwhelming and even more overwhelming discussion to the pediatricians if we would have included tracks. This is complicated enough, and from my perspective it was a good decision to start with the tracks, and maybe if we all got used to this, we can accomplish the cracks. That's our experience.
Yeah, I agree, and France will do the same, actually, to do only tracks. I know that the Nordic countries, they want to have the cracks in, but yeah. So, yeah, very quick question.
Can you roughly tell how many false positive track results of 0 tracks you see, and then it resolves?
Yes, I think from the almost 2 million babies screened in Germany since the beginning, we have roughly 100 positive, truly positive, with low T cell calls, and the distribution is quite similar to that in the United States.
How do you balance breastfeeding and nutrition for prostate results in newborn babies?
Yeah. That's a very, very important question. So I think
Can you just repeat the question for the people on the internet?
Yes, the question was, which strategy do we choose to identify the mothers who might be at risk for transmission of CMV? Is that right? Or maybe not?
Thank you. If you have a positive track newborn screening for a newborn baby who's less than 32 weeks, how do you decide to recommend to stop breastfeeding versus continuing, knowing it's very important at that age?
So for this group where we are not sure yet or cannot be sure at this moment whether they are SCID or non-SCID, is that right? Yes, I think in this situation, I haven't experienced that in our own, but our recommendation would be to freeze the mother's milk and to continue. Because if you freeze the mother's milk, or if you pasteurize the mother's milk, there is different, and pasteurization is even better than freezing. So this would be the recommendation, and continue feeding mother's milk, but take that precaution. And the risk for CMV transmission is reduced to nothing.
Thank you very much, but I think we need to go on. You ask him another time point. So thanks a lot, Manfred. And so we go on with Peter Olbricht, who is from Sevilla in Spain, but actually is a half compatriot of mine from Germany. Yeah. And so I'm happy that he will speak. We will put the timer 15 minutes, then we have some times of discussion. Thanks a lot.
Thank you. Hey. Great to be here. So I like tzatziki, but it makes me also a little bit thirsty. So that's what I'm starting. Okay. So thank you very much for the kind invitation. So I'm going to talk about something that is very, very related to primary immunodeficiencies. You know, we've changed a little bit the name. Now it's inborn errors of immunity. Also acknowledging a little bit what has been said before, that the presentation not necessarily is an infection. But let's just remember some basic stuff. So a little bit the idea is that everything may start with a specific infection or a specific disease manifestation related to an infection. And then we have to be good clinicians and decide if this may indicate the susceptibility of an individual that might be a little bit different from the general population. And then we have to decide if this is related to an inborn error of immunity, or is it because there's some anatomical reasons for having these kind of infections. And the main objective of all this is, or the main aim is, then to provide an adjusted management plan for our individual patient. And I think it's also interesting or important to go a little bit back and decide a little bit about our diagnostic process. Because, I mean, we do it every day, but sometimes it's also interesting to structure this a little bit more. Because really what we do is we collect pieces of information. We have to decide all the time, and we do this sometimes in a more or less structured way, if this information is important or is not important or is even distracting. And that can also happen with infections. We really don't know if this infection wants to tell us something in terms of diagnosis, or something what happened maybe because we did something also to the patient, or just bad luck. And in this sense, I think it's also important to consider and reconsider what we do in order to make appropriate diagnostic of infectious diseases. As we already said a couple of times during the summer school, it obviously depends also on your resources, but it's also up to us and sometimes to the surgeon or the pathologist who's taking the sample and how you or your system provides the sample then to the person who has to evaluate the sample, and then you have to make a decision if this result makes sense or does not make sense. And I think as most in the time is important to have friends, it's also important to have friends in the microbiology department or infectious diseases if you're not the infectious disease person to make the decision. And if you're the infectious disease person and you have doubts, ask your friend or colleague, because maybe often a couple of eyes more do not harm but will help your patient. Also a little bit in terms of concepts, the bugs you can find can be normal bugs. So, but then it may be that the infections are a little bit abnormal. So there could be persistent infections, recurrent infections, fulminant infections, all caused by normal bugs, so like Staphylococcus aureus, meningococcal sepsis, something like that. Or you have warts. You can have warts and that's no problem. But if it's a lot of them, maybe that's a problem. That's an indication of a primary immunodeficiency. Or you have infections also in rare places. So, for example, if you have a candida in the CNS and you have no good reason for having that, maybe you should consider also a primary immunodeficiency. And then on the other end, I think that's more clear because it's also better represented sometimes in the textbooks. If you have funny bugs, then you also get a little bit alerted and say, oh, that does not make sense that this previously healthy guy or girl has mycobacterial infection, which does not really make sense in this area. Or that we try to do something good to our patients and protect them from important infections, but they do not respond as we would expect with the protection, but with an infection to an attenuated strain, for example, of a vaccine. And sometimes, I mean, it's of course not that easy, but I find this chart very helpful to also learn a little bit Spanish. You can see todo means everything. So when you think a little bit about what bugs you can find, then you can more or less also classify your patients in terms of what cell type might be more or less affected. As I said, it's obviously more complicated than that, but at least some of the, let's say, important bugs are represented in this chart. So then we had to make, as I said, decisions. What is normal and what is not normal? And this is, of course, as Manfred also said, it's a spectrum. So these decisions might also change over time because not all patients present with a textbook in their hand and say, hey, I have all these funny disease manifestations. I am, I don't know, a CTLA4 deficiency, for example. And we have to decide also when something is not normal, but it's not due to the immune system or problems to the immune system, as I said. For example, D. George, is it because their T cells are low, or is it because they are not swallowing well, and this is why they have a lot of respiratory infections? So as I said, it's depending on a lot of other factors as well. As we also mentioned, the environment. So you can get, for example, mycobacterial disease, or you can get pneumocystis. But to get varicella, for example, you need to have some contact also with varicella. And this can be because you have siblings, or you go to daycare. You can be more prone also to infections because your parents are smoking, or you're smoking by yourself. So I think there's a lot of factors we have to weigh in. And as I said, it's important to have friends in the departments. And maybe infectious doctor may give you also an idea about that. And also talking a little about traditional tools. I think you all are aware of these guidelines or warning signs promoted by the Jeffrey Model Foundation, and I found that also in Greek. So I cannot read that, but I'm pretty sure it's the same as in the other languages. And as you may know, these are all now designed for, these are also designed now for other diseases. So CGD, for example, WIM, etc. So I think it's interesting also to check that out. But also, please remember, this has also a bias. It's very, very infectious diseases guided. So you will find a lot of primary immunodeficiencies, but you might miss also a lot of them. But it's a good starting point. And if you agree, we can have a short case. I mean, cases are mostly the best of talks, I think. So our case, the name is Joaquin, and he's 4 years old and born to non-consanguineous parents. And when he was 4 months old, he started with a lot of lymphadenopathies, intermittent rash, and fever up until 40. The family history was not very remarkable. And when he was 1 year old, he had also Salmonella gastroenteritis, requiring IV antibiotics. When we did a little bit in initial investigation, so taking some bloods, we saw that the neutrophilia was quite remarkable, 85,000, and the CRP pretty high. But we did a very comprehensive infectious screening at that stage, and it was all negative. So you can see all the things we were screening for, but it came all back negative. And when you look at the immunology studies, I'm not going to a lot of details, but it was also more or less normal for the age, unless the IgG, which was a little bit raised for the age of the patient. So he had persistent fever despite giving a lot of antibiotics, so cefotaxime, vancomycin. This is something just like an empiric coverage for this patient. And then we did a lot of things. I think this is also one of the messages. When you're worried about an infection, get as many samples, or good samples as you can get. And as I said, talk also to the microbiology lab to treat them as appropriate as possible, and also talk to your surgeon that they don't put this stuff in ethanol or something similar, because then you might lose very important information. So we did a lot of the stuff. We did a bone marrow aspiration, we did a lymph node, and a lung biopsy, because he's had also funny lung chest x-rays. But they all came back negative for infectious diseases. There were also only non-specific reactive changes. So I think everybody has seen this in a report and was very disappointed. But we were obviously very, very worried, because we were not finding any good explanation for the fever. So we changed antibiotics. That's what everybody does. When you get worried, you add antibiotics or change at least the spectrum. And we were adding even amphotericin and imipenem. Fever disappeared. Good news, and the patient was stable and could go home. However, 2 months later, he would come back. So sometimes the nightmare comes back and back. So he had fever again. He had a lot of lymph nodes, as you can see in the picture here. So everybody would say, okay, this is not normal. He had an hepatosplenomegaly and a disseminated rash again. This time the blood test, you can see 120,000 neutrophils. So people got worried about also malignancies. CRP was also high again. And then we did another lymph node biopsy, and now we were lucky and we picked up a bug, Mycobacterium fortuitum. Have you heard about this bug at some stage? It's a mycobacterium. I mean, it's in the name, so it's not. So it's from this group. It's a rapidly growing mycobacteria, and it's an NTM, so it's a non-tuberculosis mycobacteria. So that makes us then start thinking about, as I said before, funny bugs in places where you wouldn't expect them. So we have to rule out certain diseases. So this morning, I think we can go now quickly through this, because we talked about MSMDs. So to evaluate for MSMDs, you can do different things. We have seen some of these assays. So what we did with this patient at that stage, because NGS was not available for us at this time point, we did functional testing to then optimize our Sanger sequencing. So when you have the results back from your functional tests, then you can estimate how likely it is to find a problem, let's say, in the interferon gamma receptor or in the IL-12 receptor. And so what we here see is that when you stimulate the patient's cells with interferon gamma, the IL-12 production in the patient is completely absent when compared to the control. So he would not respond to interferon gamma. We also tested for the expression of the interferon gamma receptor in granulocytes, and that was coming back also negative or diminished. So the differential diagnosis at this stage was that this is a complete interferon gamma receptor deficiency. And when we did then the sequencing, we found the compound heterozygous mutation of the patient. So that was very important for us, of course, because now we had an answer for our burning question, what was happened to the patient, and despite all our treatments we were trying to give this patient, we wouldn't make him better. When you go back and think what type of antibiotics we were giving to him, it's kind of an antimicrobial treatment at the time when he was discharged. We were giving him cotrimoxazole, we were giving him imipenem. That works. This works pretty well actually for mycobacteria, but it's not standard care, obviously. And it was exactly what the father told us. Give him a little bit of imipenem and something, and he's going to get better, because it turned out he had a previous episode before when he was at the local hospital. Now, this kind of diseases, you have to fix this, because this is one of the most severe diseases in the group of MSMDs, so transplantation was performed, and he's now 4 years later fit and well. As I said, I'm not going to go too much into details because we have seen this morning, but the MSMDs is a big group, and it's a little bit confusing because you think you can only have mycobacterial disease, but that's not true. You can also have other stuff. And you can have, depending a little bit on the defect, different type of bugs. It can be bacteria, so salmonella, for example. We have heard this morning, and our patient had salmonella, if you remember that from the clinical history. You can also have some candida. So there's a little bit of everything. And most of these diseases, they are not completely penetrant, with the exception of the interferon gamma receptor deficiencies, the complete ones. And there's a lot of other examples also for infections that indicate inborn errors of immunity, and I think it's also interesting to have something like a list. So I mean, you can add a lot of them. I mean, but I think one specific candidate is what I mentioned also before, which is a candida in the CNS. So if you find candida albicans in the CNS of a previously healthy person, you should really, really consider if this is a CART9 deficiency, because it's very, very specific. So this is one of the diseases where you don't have anything else going on. You can also have other fungus, mostly of the skin, that can also make sometimes the invasive disease, but it's very, very specific. So if you think of, let's say, a paradigm of a disease in terms of infectious diseases, CART9 deficiency is really one of them. And then you have also the TLR3 deficiencies, so for the encephalitis. You have the CGD, which is mostly some of the examples people give when we talk about infectious diseases, the chronic mucocutaneous candidiasis, and so on and so on and so on. And some of these diseases are really important that we pick them up, for example, as a complement deficiencies also with the meningococcal disease. And it may also change over the time with the guidelines, because at least in Spain, our vaccine schedule gets updated from time to time. And now we maybe don't need to wait until somebody has 2 times a meningococcal sepsis to start looking for an underlying immune defect. That was more or less the strategy before we had the vaccination for everybody. Talking about vaccination, so we were talking about this also this morning. So BCG is something like the newborn screening when you don't have newborn screening. So you're going to pick up a lot of immune defects when you vaccinate children with a primary immune deficiency, mostly from the SCID area, because it's just more likely. But as I said today, that the MSMDs are more likely to provoke adverse reaction to BCG when you look in the total numbers. And as I said, the potential impact of neonatal screening also in the areas where you have a lot of consanguinity, maybe, and where usually also it's very, very likely that BCG is still part of the national strategy to protect children from complications from tuberculosis, would probably make a huge difference. And as Manfred said, it's a good idea to diagnose people before they get infections, so newborn screening hopefully will help us. And I just add another, let's say, comment to the newborn screening, because you may know that some of the diseases that you pick up, maybe not really as the target group, as you said, for example, the ataxia, telangiectasia, they can have really nasty granulomas, which are very difficult to treat. So you may pick them up, and then you wouldn't give them the vaccine which you usually give at 12 months of age. And usually when you think about an ataxia patient, most of them, they do not present until 2 years of age, 18 months of age when they start walking, and then they have gait problems. So this might be even important to consider that in this aspect. Now, the last group of diseases I would like to mention only is the phenocopies of the inborn errors of immunity, like the autoantibodies. I think we haven't tackled this during summer school, but you are aware, I guess, about the cytokine autoantibodies, which may sometimes mimic also primary immunodeficiencies. So just to give you an example for the anti-interferon gamma, antibodies. So this has been now well described, and these patients can present with mycobacterial infections as well. But there's a lot of other bugs also involved. And what you can do as a screening test is a quantiferon test, because you will get not a positive result, not a negative result, but an undetermined result, because the antibody, the autoantibody, is interfering with this assay. So I think that's also an interesting thing to have in mind. Honestly, we don't know really how to treat them. There's several case reports where you can have different approaches, from immunosuppression to also just say, okay, let's treat the disease and then it's going to get over. And I think that's really a little bit the spectrum of inborn errors of immunity, the phenocopies you can have with the autoimmunity, and then also the monoclonal antibodies we are using. And this is the last example I'm going to give you. This is ibrutinib. You know, this is like a BTK inhibitor. BTK is like Brutten's disease, so you can make a person become a Brutten or an X-linked agammaglobulinemia. This is used usually for lymphoid cancer, and interestingly, the phenotype is not completely the same as you would expect in a Brutten's disease. So you can have bacterial infections, but you also can have a lot of fungal infections. And that is not something you would really expect from somebody with a Brutten's disease. And you say, hey, that's really strange, because really when you get born with a BTK defect, and now I give only an antibody, so why would this make such a difference or make it even more severe? And the idea behind this is that you were born with this defect, so you get used to it. You give time to your immune system to adapt a little bit to this, and maybe you can compensate it somehow. And the idea comes a little bit from there, because you have also other specific inhibition of the pathway, for example, for the C5. So the inherited deficiencies, they don't have Candida and Aspergillus, but as we get used to use these kind of drugs also in the real world, we're picking up a lot of patients who make these complications. And that's probably the reason we have an acute presentation, because we make it, we convert them, let's say, in immunodeficiencies, and that also changes the phenotype. So I think, just to wrap it up, I think it's very fascinating, and we have to be prepared that we also have to include now phenocopies in our differentials. So when the NGS comes back negative, mostly in adult patients with autoimmunity, we have to think about the autoantibodies. As I said, have a friend in the microbiology lab is very good and very important. And yeah, the monoclonal antibodies, I think there's also some lessons to learn for us in terms of immunology, basic immunology, and to understand really how pathways work when you interfere with them. Okay. Thank you very much for your time, for your attention. And this is our lovely team in Seville, so come whenever you want. Thank you.
So thank you very much, Peter. We have time for one question. No, everybody's afraid. So thanks a lot. So I think in the interest of time, we go on, and I call Soler Palacinki, works in Barcelona in Spain, and I'm very happy that he will have his talk for us, when to think about monogenic causes of CVID. Please, Pere.
So thank you very much, Spina, and the organizer, for inviting me and letting me be here sharing this, I hope, interesting talk about CVID. Thank you. Oh, that's great to be speaker. So the thing is, we've been talking about that the last 2 days, and I probably will not agree what to do in pediatric and adult patients, but let's see if I can give some light to the topic. This is my disclosure. So the first thing that I think that we all agree is that we should no longer speak about CVID in pediatrics. I mean, until we have made everything to rule it out. So the famous umbrella that we had, and we felt comfortable saying that CVID, it's no longer there. So genetics do play a role in this situation. And the reason for that is that we need to offer our patients some kind of individualized care, far away from what we were doing 10 years ago, and we can do it in terms of clinical presentation, risk factors, therapeutic options, but also diagnostics. And I think that next generation sequencing do actually play a role, as it is the case for newborn screening, as Manfred was saying before. And this is obviously associated with better outcomes of our patients, despite, as we were mentioning, it takes a long time to know all the genes that may be causing these CVID patients. But not thinking only about CVID, but the whole world of primary immune deficiencies, genetics do play a role as an anticipative medicine. They are especially important in those atypical presentations. They may allow targeted therapies, which I think is a very important point, and also genetic counseling. And Manfred added more and more benefits of this kind of testing. And you have different approaches. You have the old Sanger that we did before, just thinking about which was the most possibility that looked more, I mean, you were thinking about, but we are now just using to confirm the findings of this panel, whole exome sequencing or whole genome sequencing, and every one of these has pros and cons. There are several papers looking for the usefulness of using next generation sequencing in primary immune deficiency, some of them in CVID, and as we mentioned before this morning and yesterday, they bring a diagnosis on around 15, 20, 25% of the patients, which means that 60, 70% of our CVID patients, despite maybe there's something that we don't know what it is, and we still call them CVID patients, mainly in adults, but also in pediatrics. This is an old study performed in Houston, but I think that it's quite clear to show what it offers to us to do this kind of genetic testing to all our patients with primary immune deficiencies. These were 280 families. And you can see here that they were able to catch up 60% of patients with a positive genetic result. And what it was so surprising to me is what 5% of them had a double hit, so 2 causative mutations for the patient's clinical phenotype. We can talk about later on if we have time for questions. They look what were the groups that were more prone to have positive results, and if you can see here, those were mainly those related to NK cells, because they are doing a great job in that in Houston, but mainly to T cell defects, combined immune deficiency. If you look for antibody deficiencies like maybe CVID, classical CVID, sorry, you will see that the success was lower. And what is more important to me, and you can see here change in management, which is in red, you will see that few patients, red and orange, benefit from a different treatment after your findings. So it means that in the other, we need to find a reason for doing this kind of genetic testing, because we will not change the way we are treating them. But if we move to CVID, and you know that CVID has its own criteria, we have several criteria, the ECID ones, the ECID registry one, the one from Emeratunga, the ICON, and so on, and they are not the same, despite there are some overlapping. We always think about that when we have hypogamma, poor vaccine response, or low memory B cells. Immunological dysregulation is quite common, as it is lymphoproliferation in addition to infection. And the name CVID means that you have different clinical features, different age of onset, and different severity. And the best thing of it is that it's common. It's the most common symptomatic disease, so we need to work on that. But talking about CVID, as I said before, I mean, doesn't mean nothing. You need to make sure what it is. Is it a B cell defect? Is it an antibody defect? Or is it a T cell defect? You move from combined immune deficiency, even severe combined immune deficiency, to common variable immune deficiency. And the risk of severe infections gets lower. And in the middle, you find this term by our colleagues in Germany called PCID. But, and I think that we already mentioned that before too, what is so important is before saying that a patient is presenting with CVID, always look for T cell deficiency, because if it is there, things change a lot, and you may be facing a combined immune deficiency, and obviously not only target therapies, but also the option of transplantation needs to be considered even more. Regarding genetics, there have been several studies talking about monogenic, and I will talk about later on, but also defects in transcriptomics, and mainly related to interferon gamma and epigenetics. Some papers have provided data about demethylation of B cell receptor. Several genes are involved, and they are increasing in number as we are using NGS and whole sequence and whole genome sequencing. We're finding more and more genes, and we have the example of SAGE3 this morning. And as I said before, the usefulness of doing that in our whole population of CVID patients, depend on the cohorts, but it's around, as I said before, 15–25%. And if you can see these two studies, the first one with a high number of patients found that APDS type 1 and CTLA4, sorry, it's not easy to see there, were the most commonly found defects, while in the group of Freiberg-Bodo and his colleagues found that CTLA4 and NF-kappa beta 1 were the most commonly found genes. So you can find different results depending on the cohort that you're studying. We did that study in Catalonia too, where the number of included patients was relatively low, it was just 36, and we found a success rate of 24%. But what we did next is trying to see if we can predict when a result is going to be positive or not. So the thing is, if you can do genetics easily and you have money enough, probably you need to do that both in pediatrics and adults, as we were saying this morning. But may you have limited resources, you may need to decide in whom you are doing that or not. So that's my proposal. And that's why we did this study. We worked with almost 150 patients, but we were only able to sequence 136. As you can see here, despite I'm a pediatrician, most of them, oops, you cannot see that. Here you, yes. Most of them were adults, because we are in a hospital, we do treat children and adults too, no gender differences, no consanguinity, which is so important to bear in mind because this is a Western Europe cohort. Obviously, it is so different in other countries with high consanguinity, so bear that in mind. And most of them were Caucasian, almost all of them were Caucasian. So that's, I mean, that's useful as we were saying before for our geographical area. As you can see here, they do present lots of manifestations, clinical features, lung disease, GI disease, bronchiectasis, autoimmune enteropathy in around half of them, lymphoproliferation in around 1/3, and a lot of patients while presenting more than one symptom. And as you can see here, we divided our patients into only infection phenotype and infection plus, meaning those with infection and other clinical features like lymphoproliferation and autoimmunity. And as you can see, as they were adults, a significant number, 9 out of 10, were presenting with more than infections. So bear in mind that probably that means that they need to be genetically tested. Here you can see some immunological data. Most of them have normal B cells, 15% low B cells, 58% normal switch B cells. High transitional cells were presented in two-thirds of the cohort. And we also look for serum light change to see if they could be useful to determine which patients could be analyzed and not. So at the very end, what we found is that 26% of our patients do have some kind of monogenic defect, but if you look for the detailed data here, only 2/3 of that, what means that 16% totally, were considered to be causative because we considered to be predisposing genes those patients with heterozygous TACI mutations. Here's the data for TACI, and the only thing that I want to show is that these patients did not behave clinically different to what the others did if you look for the person TACI that I showed you before. So, talking about the potential benefits of doing so, spending your time, your money, and trying to understand the findings, is that 7 patients of the cohort, which is around a 5% benefit for a targeted therapy, that means abatacept, sirolimus, and seletalicip in 1 APDS patient. And also, we were able to detect 11 unaffected individuals and 14 carriers, so that means that in terms of genetic counseling, we were able to catch more patients, so that's helpful. But what we wanted to do, as I said before, is trying to know in whom it was efficient to do that. And we got that those patients who were young, but at the moment of study, but that makes no sense because it depends on the moment that you're doing so, but mainly those patients that were young at the beginning, so low age of onset, those patients with an infection plus phenotype, and those patients with an increased transitional B cells, those patients presenting these 3 things, were those more prone to have this positive genetic testing with an area under the curve after doing a multivariate logistic regression model of almost 0.9, which is not that bad. So the thing is, That's just a proposal. And as I said before, probably for Western countries, if you are not able to do genetic testing for all your CVID adult patients, I said that we'll do it for all pediatric ones. Consider in those with infectious blast, something else, lymphoproliferation, autoimmunity, if they started at early age and if they do present with high transitional cells. I know that we all know that kind of things and that makes sense. It's logical, but we will try to demonstrate that in terms of statistical analysis, it was logical. And that's it. Thank you for your attention. I'm open to questions, so I think that we have time for that.
For this very clear talk, and thank you for respecting really the time. We have time for questions. So please, just...
Except for consanguinity, have
Yes.
you considered family history in predicting who
Yes,
you will test?
we did, but the rate of family history in our cohort was, I think, if I'm not wrong, 3.5% or something like that. So you cannot use that to decide whether it is useful or not. In terms of statistics. But obviously, obviously you have family history. That's a good point to work on that, obviously.
And how you evaluate this 3.6% family history of immunodeficiency, or you considered also family history of immune dysregulation?
Well, the first thing, it was, obviously, we needed to do a retrospective analysis of the study, despite we are still following most of our patients. But what we did is looking for their medical history. We first look for diagnosis of primary immune deficiency, which is unuseful, I think. But we also include those patients with recurrent infections, significant infections, and those patients with some kind of autoimmunity or cancer at an early age. But that was quite uncommon in our cohort. But we look for that.
Other questions? So thank you very much. So you showed us that, that's the last remark, and you know what is coming now. You saw that the genetic was more often found in pediatric patients who, in the end,
for sure,
may not be CVID.
No.
Yeah. So just the message, don't put for those who were not in the sessions in the morning, we discussed a lot this. CVID is kind of clinical and biological picture, is not a diagnosis. And so you should really not stay with this and check for, especially for young children, that you need to be sure that you are not in face of another diagnosis.
That's it.
Thanks a lot, Pierre.
Fabio Gazzotti is going to speak about primary immunodeficiencies and cytoskeleton. He is in Lausanne at Switzerland, and he's elect president of EASY. Thank you very much for coming.
Thank you, Maria. Thank you for hosting us here. Okay, what I would like to do today is to tell you a little bit of the mechanism that underlie a group of diseases, a group of primary immunodeficiency diseases that have in common the fact that they have to do with defects of the cytoskeleton. And just by way of introduction, you all know that the cytoskeleton is this intracellular structure that is composed of filaments and tubules, and what it does really gives a skeleton to the cell. It gives it rigidity, it gives it the ability of performing a series of important functions like migration, endocytosis, formation of synapses, all those functions that are very important for the immune cells. And therefore, it's not surprising that many diseases that have to do with the cause defects of the cytoskeleton result in immune deficiencies. We're going to talk about actin, cytoskeleton. We're not going to talk about the other forms of the cytoskeleton molecules. And as you all know also, I'm sure that the actin cytoskeleton is this structure formed by these long filaments of polymerized actin that also is stabilized by the synthesis of filaments, secondary filaments, or called daughter filaments, that are able to create this network of filaments in the internal of the cells. Each time the cells need to change this cytoskeleton, this structure needs to be disassembled, and therefore there are mechanisms that allow for these molecules of actin to be dissolved and recycled. As you see, this is a process that is highly regulated and composed by many different players. And as you know, in medicine, each time there is a multi-component phenomenon, there are many, many different targets that can be targeted by genetic mutations, and this is one of those cases. So in general, we have possibilities where the actin cytoskeleton is not formed or is not remodeled. And starting with some example, we have problems of synthesis of actin. There are transcription factors like the MKL1 that, when mutated, do not allow for production of actin, and that causes problems of infections and thrombocytopenia and problems of cell migration. So that is a rare form of immunodeficiency due to a problem of actin production. There are forms of gain-of-function mutations of the beta-actin gene itself, which causes for the actin molecule to be less bound by profilin. In that case, actin cannot be severed, the actin molecules cannot be severed, and the actin cannot be recycled. In that case, we have problems of remodeling. If actin is present and the actin molecules are formed, at the end of the formation, where the barbed ends are, we need to have a protection that is provided by these capping proteins. And normally this allows for to stop the progression of actin and also the protection from degradation. If the capping proteins don't work, like in the case of Carmil-2 deficiency, we have a problem. Carmil-2 is this protein that is cytoplasmic and that binds with high efficiency or affinity to the capping proteins. By doing so, it competes for the binding of the capping protein to the actin molecule. And that point, in that way, it regulates the progression of the synthesis of the actin filaments. In the absence of Carmil-2, the binding of the capping protein to the actin is not altered; it is too fixed, and the remodeling of actin also is affected and is defective. Mutations in Carmil-2 and yield form of immunodeficiency that have been described by two groups, and immunodeficiency that is characterized by infections, atopy, EBV-induced muscle tumors that I don't understand very well, and T-cell functional defects because the CD28 signal is affected. Here you can see some nice pictures of what happens to actin when T cells are activated. You can see this newly synthesized actin that collects at the cellular edge. In patients with Carmil-2 deficiency, that doesn't happen because the actin cannot be remodeled. Continuing in the possibility, what can also be affected by genetic mutations is the ability of actin to be recycled. And normally, we have disassembly cofactor that, as I said, can cut in between the molecules of actin and allow for actin to be recycled. Coronin 1 and WDR containing protein 1 are cofilin activators. In the absence or mutations that affect the function of these proteins, we have a problem of disassembly. And this results in, again, a form of immunodeficiency that has been described by Steve Holland and by Khan Bostad, that can present, again, with infections, with a neutrophil phenotype. As you can see here, there are accumulations of actin in these patient cells, or lymphoid dysfunction, again, because actin, you see in T cells from these patients, are not able to remodel normally the actin, and there are accumulations that affect the ability of these cells to function. These patients present with infection, again, neutrophil and lymphoid dysfunction, and severe autoinflammation, in addition to thrombocytopenia. You start to see a pattern here. And obviously, we are interested in these diseases because they are immunodeficiency, they present with infections, but there's also some other features that come from other classical characteristics of the IOS classifications, and therefore also from the autoinflammation category. In addition, we have a whole series of diseases that have to do with malfunctions of the nucleation promoted factors, the prototype of which is the Wiskott-Aldrich syndrome protein. The nucleating promoting factors are those molecules that are able to bind globular actin and bring it close to the RP23 complex so that a daughter filament can be synthesized. In the absence of the Wiskott-Aldrich syndrome protein, you all know we are in the presence of a disease, of the Wiskott-Aldrich syndrome disease that is characterized by thrombocytopenia, eczema, infections, and susceptibility to malignancies and autoimmunity. This disease is due to the fact that WASP here is missing. Normally, WASP is activated by the activation of CDC42 through the function of DOCK8. And normally, as I said, it facilitates the synthesis of daughter filaments. In the absence of WASP, there are problems of synthesis of many forms of actin, but most evidently the problem is with the formations of microvilli. As you can see here, there is a T cells from a Wiskott patients are many fewer microvilli and malformed microvilli compared to a control cell. In addition, since we know Wiskott derives from problems of that are at the level of the RP23 complex, we could have expected that there is a immunodeficiency based on defects of cytoskeleton due to mutations of one of the components of the RP23 complex, and so it was not surprising to see the description of the RPC1B deficiency, a disease that is very similar to Wiskott. It's a little more, even more severe, but it's also characterized by vasculitis, severe infections, and eczema. And if I want to show you this beautiful picture because it shows how a megakaryocyte, a normal megakaryocyte, where all these proplatelets protrusions form, is completely abnormal and dysfunctional when you delete the RPC1B gene into it. So this is a clear evidence or a clear demonstration of how actin is important in dysfunction, in particular in dysfunction of protein production and generation. Now, what I also wanted to tell you that in addition to the cytoplasmic cytoskeleton, there is a specialized portion of the actin cytoskeleton. There is the cortical cytoskeleton. This is a portion of cytoskeleton that is formed or composed by a series of fibers that run parallel to the cell membrane, and they are connected to the cell membrane by the ERM proteins, ezrin, moesin, and radixin. And of course, problems of this connection can lead to a form of immunodeficiency. In this case, it is the IXMADE disease characterized by infection, cytopenias of all kinds in this case, and adhesion migration defects. Here, this region of the cytoskeleton is also very interesting because that is where we find the small G proteins of the families of RAC, Rho, and CDC42. We already talked about CDC42 and the importance that he has in activated wasp in the formation of Philopodia. RAC and Rho have similar functions. They are responsible for activating other nucleation promoting factors, VASP and WAVE. And when they work normally, they are responsible for promoting the formation of stress fibers and lamellipodia. Of course, genetics has shown that those molecules are important. Mutations in CDC42 lead to a severe and early onset disease, neonatal onset cytopenia, autoinflammation, rash, and HLH. Since CDC42 is activated by DOCK8 deficiency leads to a disease that is represented by a lack of CDC42 function, and which is very similar to the Wiskott-Aldrich syndrome. Also, genetics has showed us that RAC2 is important, and his function in the cytoskeleton remodeling is important. RAC2 loss of function mutations cause a severe form of neutrophil dysfunction with recurrent abscess, severe abscess. RAC2 gain of functions leads to a form of SCID. And since DOCK2 is the guanine exchange factor that activates RAC, DOCK2 deficiency also leads to a disease that has to do with the formation of actin components like lamellipodia, which also is not too different from the WASP with the Wiskott-Aldrich syndrome and DOCK8 deficiency. DOCK2 and DOCK8 are described here, diseases that are characterized by infections, lymphopenia, and defective lymphocyte migration. In addition, DOCK8, which is a bad version of the Wiskott-Aldrich syndrome, is also characterized by increased levels of IgE, skin infections, atopic dermatitis, recurrent pneumonias, and susceptibility to cancer. Now, I give you a very quick rundown of the diseases that are connected to the defects of the cytoskeleton. In this table, I try to summarize the important features, clinical features, and laboratory features of these diseases. So, not unexpectedly, and the reason why we are interested in them, most of them are presents with recurrent infections of different kinds, viral and mycobacterial, bacterial, but they all are diseases that we see as primary immunodeficiency experts because they come to us, they come to our attention, but also, as I said, they come from other categories of the IOE's classification. So they come from the autoinflammation and the autoimmunity group of disorders. From the biological point of view, the laboratory will show some degree of lymphopenia, but also problems of lymphocyte function, like defective proliferation, it's comprehensible, problems with NK and T cell function. What is unique and also very easy to understand, and in most of these diseases, migration defects and chemotaxis defects have been demonstrated again. That is a feature that is explained very well by lymphoid and myeloid problems. So what I tell my students all the time is that when you see a patient that has an immune deficiency but combines problems with the lymphocyte cell type and thrombocyte and presents thrombocytopenia or neutropenia, your attention should be put on one of these diseases, perhaps some new ones that are connected to cytoskeleton problems. And when I say perhaps some new ones, is because certainly we have not done looking for gene connected with cytoskeletal dysfunction. Here we are looking just at the molecules that are active in the cytoskeleton function of B lymphocytes. There are around 50 genes here, and only 4 of those so far have been identified. And I'm sure that some of these genes are, when mutated, would be too deleterious to be compatible with life, but I'm also confident that we'll find a few more that underlie some human disease. And I'll stop there, and I'll take any questions if there are any.
Thank you very much. And there is time for the 3 minutes for questions.
Why do what? Is that on? No.
Yes.
I didn't really need it. I've broken it. Is that? But yes. Do you understand, or can you explain the mechanism for the inflammatory complications that you see in many of these patients, like vasculitis and granulomas?
So no, I don't think I can explain it. And then what we say is that there is a problem of migration of these cells, and therefore an activation that remains local and create inflammation. That is what we talk to each other about, but hasn't been proven in any kind of meaningful model.
What is the treatment? I mean, is stem cell transplantation working for this patient?
Yes, for most of these patients, I think you should be looking at bone marrow transplantation for a definitive cure. For some diseases, you can envision the identifications of molecules that can counteract the effect of the mutation. For instance, for Wiskott, if you find a molecule that could be similar to WIP, that can bind to a missense mutation that causes a early degradation of the molecule, you can potentially have a medicine that you can give to these patients. For Camille, also, you could think about a molecule that binds to a capping protein and remove them and try to balance that absence. But in most cases, these diseases require definitive therapy in terms of transplantation or gene therapy that has been developed, at least for the Wiskott-Aldrich syndrome.
Thank you very much.
Thank you.
So we'll have 15 or maybe 10 minutes.
20 minutes.
20. Okay. Thank you very much.